Hello there, this is part 3 of our well-defined multilocular lesions, the MACHO lesions. And we've actually already covered all the MACHO lesions. We covered odontogenic keratocysts during the well-defined unilocular lesions, so just remember that that one can present as a somewhat multilocular lesion as well. That's why it's on this slide. We also covered aneurysmal bone cyst, and so now we're going to talk about the rare tumors: squamous odontogenic tumor, glandular odontogenic cyst, central odontogenic fibroma, and desmoplastic fibroma. These are pretty rare, so they may not appear that often on your differentials, but it's good to be familiar with them. Then toward the end of this lecture, we're going to go over several cases and see what you've learned. So let's get started. First, the squamous odontogenic tumor, SOT we could refer to this. There are theories that these may arise from perhaps the epithelial rests of Malassez or neoplastic transformation of dental lamina rests. Wide age range, so nothing specific there. Let's get to the imaging features, which are not super specific, although I will say one thing. If you see separation of teeth in kind of a triangular appearance, so a radiolucent triangle defect lateral to the roots of teeth, maybe think of squamous odontogenic tumor. These can be well defined, but that somewhat varies. In fact, looking at this, I would say that it's somewhat ill-defined lesion, but the fact that it's pushing teeth apart tells you it's something that's displacing teeth, something that may have more of a solid mass to it like you would expect with a benign tumor. All right, another rare one, glandular odontogenic cyst. It can also be called sialo-odontogenic cyst. This one includes mucus-producing salivary gland cells. That's where it gets its name. It's glandular. This is not very distinguishing. A lot of tumors tend to occur in the Middle Ages. And what does this one look like? Notice I have kind of the cystic slide showing again. It does behave like a cyst, but it can look like multilocular, which is why it's in this lesion. It occurs in the anterior mandible, so that's somewhat unique. Another big thing, the way I kind of remember this one is if you see something that looks maybe like a CGCG, maybe not quite those wispy granulation, but the anterior mandible multilocular lesion in an older patient, then think this one. So you may be thinking CGCG because of the location, because it's multilocular, but it's typically in an older patient than your CGCG. That's when I think GOC, or glandular odontogenic cyst. See some of these examples, very soap bubble, so you're probably thinking, what, a myeloblastoma? Although they're somewhat larger soap bubble appearance, somewhat larger loculations, but the location of it, similar to a CGCG, older patient, CE dentulus here, that's when I start considering the glandular odontogenic cyst. And then similar to a CGCG, the mucosa can start to appear purple because remember, it has that glandular tissue in it. It's salivary producing tissue that's very liquid inside. Another example, kind of expanding the teeth apart, well-defined corticated, somewhat has that soap bubble appearance, but now we're starting to lose a lot of those loculations. And then differential, why CGCG not on here? Because usually there is an age differential. But if you're going through your head and just describing it, and the description is starting to look like CGCG, but you've got an older patient, good chance it's going to be this one. But then the soap bubble appearance, it may look a lot like a myeloblastoma. Some of those look like OKC if it starts to lose those loculations. We'll talk about central mucoepidermoid carcinoma coming up. That's kind of a benign mimic that happens to be malignant. These do have a fairly high recurrence rate, and so resection might be considered for these. And then odontogenic fibroma, or central odontogenic fibroma. These are again rare, somewhat more prominent in females, can be unilocular or when large, multilocular, with fine straight granular septation, so makes it a myxoma or a CGCG mimic. One thing that may distinguish this is when you see that cleft or a depression inside the palate like we see here. First of all, if I saw that, I might think a minor salivary gland malignancy, but it could also be an odontogenic fibroma, which is a benign lesion. So look at the radiographic appearance. Hopefully more well-defined, but these can vary as well. And so with these internal septation that can be fine and straight, it can look a lot like a myxoma. Same age range as myxoma, so this might be one to have in the back of your mind when you have myxoma on the differential. Could it be odontogenic fibroma? Because a lot of similarities there. But here again, we're seeing that picture of the defect in the anterior palate. It's eroded through both the buccal and palatal cortices here. So that's something that can happen with odontogenic fibroma. All right, and desmoplastic fibroma typically behave more aggressively. They invade the soft tissues. The septation are thick, unlike what we saw with odontogenic fibroma. Might be impossible, like I was saying, to differentiate from a myxoma. So maybe that's one to kind of marry in your differential whenever you have myxoma. And as well with CGCG, these tend to have granular septation, just like central giant cell granuloma. But if it is a true odontogenic fibroma, it does have a low recurrence rate, so a simple excision should do. So desmoplastic fibroma, also called aggressive fibromatosis. This is the aggressive one in the rare group, and it's non-odontogenic. So children under 20 can have this, fairly young age group. So this is one, it may have the same age features as CGCG, so you might be thinking CGCG, aneurysmal bone cyst, but it doesn't tend to expand as much as those, as be aggressive and destroy things. Maybe the borders are a little more ill-defined. And this is something that can occur as part of Gardner's syndrome, so keep that in mind. And so there's nothing super distinguishing about this one, fairly young age group. So maybe again, when you're thinking CGCG, but it's more often, these are more often posterior. So CGCG and you see in the posterior, maybe you'd think desmoplastic fibroma. And yeah, these are so rare, I don't have a lot of examples of them. So maybe something that you'll never see. What's interesting here, now we have in our differential diagnosis of malignancy, a fibrosarcoma. But if it has those multilocular appearances, trabeculation, think more desmoplastic fibroma than a fibrosarcoma. And so it does tend to have more irregular borders than most other benign things. So again, this might be something to differentiate from myxoma. And now if you're looking at all these previous lesions and think they all kind of blend together, well, don't worry too much. These last few lesions are really rare. You may never see them. Maybe you can lump some of these with other differentials. A lot of these look like they could be myxoma. And so if you have myxoma on your differential and it ends up being one of these, I would say you're mostly correct, right? You're in the right ballpark at least, and that's where you need to be. So now let me test you. Let's go through some cases and see how we do. All right, what does this look like? A lot of times the first thing I look at in a radiograph is say, okay, what's the age of the patient? This is an older patient missing quite a few teeth, right? Some serious periodontal disease. And then look at the borders of the lesion. Are you thinking more ill-defined or more well-defined? Are you thinking more something maybe malignant or something more benign? And this has nice, clean, very corticated, smooth borders. So something very well-defined, but it is destroying the alveolar bone here. So it's well-defined, maybe a little bit aggressive here. What's the expansion pattern like? Well, that's a little bit hard to say. The specimen here shows you a little bit about the expansion. It is expanding somewhat toward the buccal, and imagine it expanding toward the lingual a little bit as well. And so what are some of the things on your list? Does it look multilocular as opposed to unilocular? I would say, yeah, there's a little hint of loculations here. And so think of our MACHO acronym. What's that? Myxoma, amyloblastoma, CGCG, hemangioma, and OKC. What are most likely out of those ones? Well, think about the common ones, amyloblastoma, OKC. You can't go wrong with that. And those are the two that probably belong most on the differential. You do want to be wary if it may be a hemangioma coming from the mental foramen. But let's look at the histology. And I'm not going to talk too much about histology in this course, but I guess a brief introduction. You do have these islands of epithelium. This is epithelial tissue. It has reverse polarization of the cells, meaning the nuclei are on the outside of these little islands. And that's kind of classic for your solid, your most common appearance of an amyloblastoma. All right, next case here, we see these well-defined, nice round lesions. Hopefully right away you notice the cortication of this and you're saying, yeah, this is definitely more of a benign thing. Little hints of septations in here. So I would describe this as somewhat multilocular. The appearance is more radiolucent here, tells me that it's probably eroding through the lingual cortex here, and in the rest of the lesion it's just eroding through the buccal cortex. And so how expansile it is. What's the expansion pattern of this? It's more up and down the bone following the length of bone, and not so much, we can't really see the buccal lingual, but it doesn't look like it's that much buccal lingual, and not so much inferior superior, or in this case, mesiodistal. And so this expansion pattern is more similar to an OKC as opposed to amyloblastoma. Again, those would probably be top of the differential, those two. But that's what this ended up being, an OKC. Maybe some little hints that it could be amyloblastoma, although any of these benign tumors or cysts can do it, is resorption of the roots of these teeth. And so you have a lot of different signs and you have to weigh them against each other and choose, okay, what does it tell me more? And I think really the expansion pattern of this tells you it's more OKC than it is amyloblastoma. All right, how about this one? Hopefully you can get this one right away. Think of our MACHO acronym. How expansile is it? So the expansile pattern is more along the bone than it is buccal and lingually, just slight buccal lingual expansion for how large this is. And then look at the septation. Remember the start of the last lecture, I said the key thing is going to be how these septae appear. And how does that look? Does it look soap bubble, nice and round? Or does it look more polygonal? Yeah, that's the more polygonal septations, or the straight septations, the polygonal locules. And that was what? That's our myxoma. So hopefully you got that one. What about in this case? We see well-defined corticated margins. We're thinking, okay, well-defined lesions. Is it somewhat multilocular? I don't know, maybe that's debatable. Maybe you can go back to your unicystic lecture. But look at the expansion pattern again. And then this axial slice shows really nicely one thing. It's kind of scalloping in between roots. When you see scalloping, think two things. You think simple bone cyst or OKC are kind of the main things that do that. Maybe myxoma. I don't see any other signs of myxoma with the straight septation in this case. And so really I'm thinking simple bone cyst, OKC. Does simple bone cyst expand even this much? They can get somewhat large, but when they expand, it kind of maintains the lamina dura around the teeth, which we don't see here. So of those two, again, this looks like an OKC. All right, what about this one? Well-defined or ill-defined? Does it look like something malignant or benign? You can see some cortices right here as it outlines this lesion. And what are the arrows pointing to? Septations in it. This is one of our MACHO lesions. But what type of septation? Is it the soap bubble appearance, nice round coarse appearance of the septation? Is it more the X shape? It kind of does have that straight septation appearance. But what I really want you to notice about this one is how those septation appear. Is it nice and well defined, like someone drew it with a pencil, or more kind of wispy and granular? What does that tell you? The wispy granular septation, that was unique for CGCG. So that's what I think stands out here. Maybe I'd have myxoma second on the differential because it does kind of have that straight septation appearance. This just anterior to the first molar, if we knew the age of the patient, they look fairly young. Now, this patient could be 20 or younger. And so a CGCG. What's the second thing I said to have on the differential for CGCG? I always think aneurysmal bone cyst as well. Tend to be even more expansile, maybe more posterior, but this is posterior enough that I'd probably consider it. And so those three things I like best about this one as far as the differential. CGCG, myxoma, aneurysmal bone cyst. And that's a really good differential for what you see here. What about this one? This might be one of the more rare things. Hopefully you can appreciate that it does have well-defined smooth borders in a lot of the area. Although it's not perfectly well-defined, doesn't have really strong cortication. It does have somewhat of a multilocular appearance. It has nice round loculation, so you might be thinking of myeloblastoma, but usually myeloblastoma, the solid type, has very distinct septations, which we're not seeing as well here. So maybe a myeloblastoma. What else are we thinking from our MACHO acronym? Well, let's look at the age of the patient. Can you appreciate this is a fairly young patient? Not very old. They still have nice, strong cusps. Just a couple of restorations, not a lot of periodontal disease. Somewhat young, probably younger than middle-aged patient. And so what fits that description? Maybe CGCG, myxoma, and the average is around the 20s. I don't see a lot of signs of myxoma. Let's get back to CGCG. What about location? Yeah, that fits too. So we're getting a lot of green lights, I think, with CGCG, and this turned out to be a CGCG. Doesn't have that super well-defined loculations, septations that you're going to see in some of these other lesions. When I first look at this, the nice smooth borders, what went through my mind was glandular odontogenic cyst, but that's why I said, okay, look at the age of the patient. Glandular odontogenic cyst, the examples I gave you, the patient was edentulous. It was an older patient. This is a younger patient. And so this really fits with CGCG. If you talk about maybe scalloping between roots, maybe you would think of simple bone cyst, OKC. What I like best is maybe CGCG and OKC as the top two on the differential. Why don't I like simple bone cyst? Well, it's somewhat expanding. Looks like it's kind of eroding into the inferior cortex here. And so, yeah, I like those two. And this is a CGCG. All right, what about this one? Do you appreciate that it's somewhat multilocular? It's somewhat well-defined. Maybe parts of it are not super well-defined. You can't really see those corticated borders around it. But what's one sign that's really telling you this is more likely something benign than malignant? Look at the drifting of the teeth. Look how it's expanding the roots of the teeth apart. And that's a strong indicator of potentially something benign. Rarely malignancies can do it, but that's pretty rare. And they'll have other signs of malignancy as well. And so something benign, maybe borderline well-defined, that's not super clear. Multilocular has these small loculations. What are you starting to think? Small loculations. It kind of fits that honeycomb description. And we use that for our hemangioma, the H of MACHO, or arteriovenous malformation. Well, this image should give it away. We did an angiogram, so injected a radiopaque dye. And yeah, all this malformation of venous or arterial structures goes here in between the teeth, and that's what's causing it. Not a true benign tumor, just a proliferation of blood vessels. And so this was our hemangioma, or likely a arteriovenous malformation. All right, so that's our MACHO acronym. Remember, myxoma with its straight septation, a myeloblastoma with its curved soap bubble appearance, maybe sometimes that honeycomb appearance,
CGCG and its vascular cousin, the aneurysmal bone cyst, granular, wispy septation, expansile, hemangioma, or better called AV malformations. Honeycomb sometimes has that sunburst appearance, or it can have the serpentine canal appearance, and those are very dangerous. Be really wary of those. I would just recommend anytime you cut into a bone lesion, aspirate first before you really cut into it, unless you're prepared to stop excessive bleeding. And then OKC from the last topic, we talked about the expansion of that, more going along the bone. It can appear multilocular, that's why it's on this lecture, but usually it's somewhat limited in the locular appearance. If it has a nice soap bubble appearance, go more toward ameloblastoma. But the expansion pattern, like I was saying, I call it the banana shape expansion pattern. It just goes along the jaw and not so much outward. That's true for OKC as well as myxoma, if we go back to that one. And then rare tumors sit behind those. If you take one habit from this video, read the septae. If you take one warning, never biopsy a lesion that might be vascular. All right, so in the next topic, we'll talk about well-defined radiolucencies with internal calcifications. That is our cacao differential. We'll get to that acronym. So this one was MACHO. Next one's going to be cacao. We'll see you on that next one. Thanks.